My name is Shannon Lake, and this is my presentation on my capstone project, which was the development of a vascular access team. The purpose of this project was to highlight the potential benefits of developing a vascular access team to decrease central line-associated bloodstream infections and increase patient satisfaction. Phlebotomists tracked patients with difficult vascular access for a period of 30 days, and it was found amongst the data that 73 patients during this time period required at least 2 attempts to get blood. This data shows the significant impact that the establishment of a vascular access team can have on patient care. Vascular access is one of the most commonly performed procedures done by a variety of healthcare workers in the clinical setting. Difficulty in gaining vascular access not only causes multiple attempts for peripheral intravenous catheter insertion, but also increases the need for a more invasive vascular access device, such as central venous catheters and peripherally inserted central catheters. Reducing the number of these invasive vascular access devices can also reduce the incidence of central line-associated bloodstream infections, or CLABSI, in these patients. Selecting the right device for vascular access on a patient upon initial evaluation helps to minimize these risks and costs. And having the availability of personnel skilled in placing vascular access devices can mitigate these risks and reduce the incidence of CLABSI. These skilled personnel utilizing midline catheters to avoid the use of central catheters also shows a reduction in CLABSI. Midline catheters are useful in patients with difficult venous access and have a similar infection rate when compared to a PIV. Both have an infection rate significantly lower than PICCs and CVCs. In developing a dedicated vascular access team, the goal would be to reduce the use of PICCs and CVCs in order to reduce the incidence of CLABSI and decrease costs associated with CLABSI and difficult venous access, or DVA. At St. Patrick's Hospital, the 2020 goal for the rate of CLABSI is a standard infection ratio of less than 0.696. The development of a vascular access team, or VAT, will assist us in reaching this goal. An extensive literature review was conducted using the University of Providence online database, Academic Search Complete, Google, and PubMed. The term central line-associated bloodstream infection, or CLABSI, vascular access team, or VAT, VAT for infection prevention, difficult venous access, or DVA, line insertion techniques, and a search for vascular access devices, including central venous catheters, or CVCs, midline catheters, or MLCs, and peripherally inserted central catheters, or PICCs, were all utilized. These terms were used to consider all aspects utilized in the prevention of CLABSI, different types of vascular access, how a VAT can decrease CLABSI incidence, and improvements that can be made to maximize current insertion and maintenance guidelines. Articles in journals not in English were not included, and only full-text articles were used. Journals from all dates were accepted for definitions and description purposes. If it was a journal used for percentages of incidence or to represent current data, only dates in the past 5 years were used. For a total of 25 references, 14 of which were meta-analysis, 9 were cohort, and 2 were retrospective studies. While performing the literature review, a good mix of study designs were found. The one most frequently seen was meta-analysis, which is the most frequently cited form of medical research since it started to become more frequently used in the 1970s. Meta-analysis is a quantitative systematic gathering of information from previously performed research studies. Rather than just focusing on one place and time, meta-analysis brings together studies done by multiple people on the same or similar thing. This means that a meta-analysis covers a larger group over different times and places. One aim of a meta-analysis is to improve the strength of evidence. For this study, it was nice to have multiple studies in one place that discuss the benefits of a vascular access team. The downfall was that there will always be some level of bias due to the studies that were either missed or left out. Research topics that were focused on included vascular access devices, including complications and costs, and studies comparing different devices, central line associated bloodstream infections, including guidelines and compliance in place to prevent CLABSI, and vascular access teams. The facility in this study is a 217-bed acute care hospital that could see a benefit in developing vascular access team. For this plan, two different theories are utilized to promote change. The first theory is PDSA, or Plan, Do, Study, and Act. This four-part plan was used in this study, with the plan portion of this change to include the literature review that was performed to show the benefits of developing a vascular access team. The do portion of this changes is in two parts. For approximately 4 weeks, difficult vascular access patients will be informally tracked by staff using a checklist to record various data. After 4 to 6 weeks, the results of this study will be analyzed to determine the need for a pilot vascular access team, with the number of team members to be determined based on the first step. The study portion of this change will be observing any positive or negative impacts that are a result of the pilot study. The ACT portion will be making changes to the study as needed. The second theory utilized is theory of change, and that worked in this study as a way to develop a long-term goal to develop a vascular access team, and then we were able to work backwards to develop steps in order to achieve that long-term goal. Establishing a vascular access team requires collaboration among a varied group of people. Financial staff and administration are a necessary part of collaboration to assess the implications of this proposal, both financially and to oversee any clinical restructuring. It is something that will have upfront costs related to hiring and training. Administration will have to be a part of approving the funding for training and paying a specialized staff. Whether the vascular access team is formed from internal candidates or external, it will require the hiring of some additional staff. They will have to be fully on board to support the establishment of a vascular access team, with the realization that the benefits outweigh the cost. Infection prevention and nursing will assist in establishing policies and training. They, particularly the nursing managers, will help decide how large of a vascular access team is needed and what hours the hospital will be staffed with a vascular access team. Physicians can be of help with that as well as lending support to the vascular access team that will be comprised of an interdisciplinary team of nurses, doctors, infection prevention, and interventional radiologists that will assist in guiding the formation of the team and participate in training. This project has had several barriers, both expected and unexpected, not least of which was the unexpected COVID-19 pandemic. Beyond that, two expected barriers were having nursing pushback when asked to help track patients with difficult venous access, and pushback when and if the time came to create a pilot vascular access team. The expected pushback from staff in tracking DVA patients was expected because they were going to be asked to perform extra work in a situation that was already difficult, and incentives were going to be offered to relieve some of that pushback. In the development of the vascular access team, we would be asking people to take on more responsibility for no financial incentive, but the nursing managers could help to explain the benefits of the vascular access team and and impress upon the nurses that are interested in the chance to not only improve their job performance by learning a more in-depth vascular access technique, but they could also see it as an opportunity to become part of a permanent vascular access team in the future. The biggest barrier faced during this project was the emergence of the COVID-19 pandemic. Because of the pandemic, during this study, there was a low hospital census compared to what we were used to. Nursing, management, infection prevention were already loaded with new guidelines and new work, and it was not possible to ask them to learn another new technique during this time. Because of this, help was sought from the phlebotomist to track the difficult venous access patients for 30 days. Vascular access to patients is one of the most essential parts of enabling the assessment and treatment of patients. Difficulty gaining vascular access can increase the need for more invasive vascular access and increase the chances of CLABSI. For St. Patrick's Hospital, the goal for CLABSI rate in 2020 is an SIR of less than 0.696. The increased use of midline catheters when PICCs and CVCs can be avoided can assist in decreasing this problem. The formation of a dedicated vascular access team to evaluate and manage these patients can reduce infection rates and decrease costs overall, as shown in other facilities. For the expanded literature review, it was conducted to establish more evidence that a vascular access team is beneficial and to review guidelines already in place by the CDC to reduce the incidence of CLABSI. Many different types of study designs were used, with the main design being meta-analysis. Both theory of change and Plan, Do, Study, Act was utilized in this project to organize change. Roadblocks considered in this project included pushback from nursing in the collection of data and the formation of a pilot vascular access team, along with a novel coronavirus pandemic. These roadblocks caused changes to be made from the original proposal, including the use of phlebotomists instead of nurses to collect data. For this project to come to fruition, an interdisciplinary team comprised of representatives from the administration, infection prevention, doctors, and nurses will be among the key stakeholders. The author began this project with the idea that St. Patrick's Hospital would be in a position to establish a vascular access team upon completion of this project. Because of the many barriers, not least of which was the coronavirus pandemic, the project fell short of this goal. One of the major parts of the proposal that was unable to occur was the development of a pilot vascular access team. This would have helped work out logistics such as the size of the team needed and the hours the team would be staffed. In the absence of that and the inability to collect data from nursing on patients with difficult venous access, having the phlebotomist track these patients worked well but was not the first choice. Now moving forward, the author has compiled the data that was collected and condensed it with the information found through research and produced a PowerPoint that can be used by Infection Prevention Department to propose the idea of a vascular access team to administration. This will ideally put them on track to receive the permission needed to pick up where the project left off. It is the hope that this will enable them to begin a vascular access pilot program to show the benefits of establishing a permanent team. With all of the barriers that this project was up against, the willingness of people to help was the best part of the project. Speaking to phlebotomists and nursing, the prospect of a vascular access team at this facility was met with some excitement and fueled the willingness to assist in whatever was needed and solidified the importance of this project. Additionally, the literature review was extremely beneficial. The author was able to find studies that applied directly to this facility, both in size and population.